Patients here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application
for 45 minutes of CPR. We can stop CPR with 600, 600, 600.
You know, usually when we talk about a medical diagnosis or a treatment plan, there's this expectation of precision, like engineering.
Right, exactly.
You break your arm, the x-ray shows a jagged white line, and the provider just points and says, there it is, broken.
It's binary.
Yeah.
And, I mean, that's comforting. We naturally like things to be visible, to just be easily categorized and, put into a neat little box.
Yeah. But then you step into the world of neurodevelopment, trauma, and psychiatric pharmacology, and suddenly that x-ray machine is it's completely useless.
Oh, totally useless.
We're looking at a diagnostic and therapeutic landscape that is incredibly murky. It is definitely not binary.
It is the absolute definition of diagnostic muddy waters. And for those of you listening right now, whether you are prepping for a really tough clinical rotation, studying for the NCLEX, or maybe you're already practicing on a busy psych or med-surg unit, psychopharmacology can feel, honestly, completely overwhelming.
Oh, for sure.
You're handed these massive, dense prescribing guides, and it is entirely too easy to just drown in the minute details.
Which is exactly why we were here. So, welcome to the Deep Dive. Today, our mission is to step into the roles of an elite clinical pharmacist and like an expert nursing instructor.
Yes.
We are looking at a heavy-hitting medication today, the antipsychotic risperidone. And our approach here is simple. We are going to apply the Pareto principle.
I love that approach.
Right. We're going after that crucial 20% of the information that will give you 80% of the practical understanding you actually need for, safe, confident clinical practice. We are going to synthesize a mountain of chaos into clear, actionable clinical judgment using a strict 12-step breakdown.
Perfect. And to do that, we really have to start at the absolute foundation. Because before you can safely administer any drug or anticipate its side effects, you have to understand its identity.
Exactly.
You have to know exactly how it is rewiring the patient's brain chemistry.
Okay, so let's lay out the blueprint. Step 1, medication name and class. The generic name is risperidone. But in clinical practice, you are going to see it under several brand names, mostly tied to its injectable depot forms.
Yeah, you've got a few of those.
Yeah, you've got Risperdal Consta and Rekindo, which are intramuscular or IM injections. And then there's Perseris and Uzity, which are given subcutaneously.
And as for its class, it is a serotonin-dopamine antagonist, which, falls under the broader umbrella of atypical antipsychotics.
Okay.
But before we get into the brain chemistry, there is a very practical, very recent safety update regarding its classification that floor nurses really need to know about.
Oh, wait, the NISH update? Yeah, I saw this in the text. Risperidone was actually removed from the NISH Group 2 list of hazardous drugs, right?
Yes, exactly. It's a significant update for workplace safety. It basically means the governing bodies have determined that handling risperidone does not pose a carcinogenic, reproductive, or developmental hazard to the healthcare workers administering it.
Wow, that's good to know.
Yeah, you don't need the extreme hazardous drug precautions that you would for, say, an active chemotherapeutic agent.
I mean, that is a massive relief if you're the nurse crushing or preparing this medication day in and day out. But let's look at steps 2 and 3. What the drug is actually doing once it's inside the patient.
Mechanism of action.
Right. To understand the therapeutic effect, I kind of like to think of the brain as a complex soundboard in a recording studio.
Okay, I like that analogy.
When you have a patient with schizophrenia, the dopamine volume is cranked way too high in certain areas, and that's what causes those positive symptoms, the hallucinations, the delusions. So risperidone comes in and basically turns that specific dopamine dial down.
It does, yeah. Specifically by blocking D2 receptors in what's called the mesolimbic pathway. That's the brain's reward and emotion center.
Right.
And our text notes something really fascinating here. The optimal receptor blockade is right in this sweet spot of 65% to 75%.
Oh, really?
Yeah.
That specific?
Yeah. If you block less than 65%, the hallucinations remain. But if you block more than 75%, you start triggering severe movement disorders. So that specific range gives you the therapeutic effectiveness while preserving safety.
But older, typical antipsychotics basically just took a sledgehammer to the soundboard, right? Like, they crushed dopamine everywhere. So what makes risperidone atypical?
The atypical twist is its high affinity for blocking serotonin receptors, specifically the 5-HT2A receptors in the prefrontal cortex. This is where the pharmacology gets, frankly, brilliant.
Okay, how so?
When you antagonize or block serotonin in that specific frontal area of the brain, it actually triggers a local increase in dopamine release.
Wait, let me make sure I have this straight. It's blocking dopamine in the emotional center to stop hallucinations, but it's indirectly boosting dopamine in the frontal lobe.
You've got it. That's exactly it. And that local increase in dopamine in the prefrontal cortex is what treats the negative symptoms of schizophrenia. You know, the blunted affect, the lack of motivation, the profound social withdrawal.
It kind of brings the patient's personality back online.
Exactly. Plus, that delicate balance significantly decreases the likelihood of extrapyramidal symptoms, or EPS. Those are those awful, rigid movement disorders you see with the older drugs.
So it's perfectly tweaking the serotonin EQ while turning down the dopamine volume. But looking at this receptor map in the text, it's still a pretty messy drug, isn't it? Like, it accidentally hits a lot of other buttons on the soundboard.
Oh, it's extremely messy.
Yeah.
And as a clinician, knowing those accidental button pushes is what allows you to predict the side effects.
Right.
For instance, it strongly blocks D2 receptors in the tuberoinfundibular tract.
Which is the pathway connecting the hypothalamus to the pituitary gland. So blocking dopamine there causes a massive release of the hormone prolactin.
Exactly. It also blocks alpha-1 receptors in the peripheral blood vessels.
Which means the blood vessels can't clamp down and constrict when the patient stands up, causing severe orthostatic hypotension.
Bingo. And it also has a high affinity for blocking H1 histamine receptors in the brain.
Hello, profound sedation and metabolic weight gain.
Right. When you understand the mechanism, the why memorizing side effects becomes totally obsolete. You can just deduce them.
That makes so much sense. And understanding how it rewires the brain naturally leads us to step 4, asking who actually benefits from this drug, and more importantly, who could be severely harmed by it. Let's look at the indications.
Okay.
The primary FDA-approved uses are for schizophrenia in adults and teens, acute mania or mixed episodes in bipolar disorder, and irritability associated with autism.
But you will also see a really robust list of off-label uses in practice. You'll frequently see it prescribed for moderate to severe attacks in Tourette's syndrome, extreme disruptive behaviors in conditions like ODD and ADHD, and even acute delirium in the pediatric intensive care unit.
Man, treating a child with such a powerful antipsychotic, that just feels incredibly heavy.
The clinical weight of that decision is immense. That's why dosing for pediatric populations requires starting incredibly low.
How low are we talking?
We're talking 0.25 milligrams, or weight-based dosing, starting at like 0.01 milligrams per kilogram per day. The physiological impact is so strong, you really have to tiptoe in.
Yeah, that makes sense. But the most vital part of the prescribing guide, step 11 and 8, the part that every nurse and student absolutely must memorize, is the black box warning and the contraindications.
This is crucial.
This is the grave reality of this medication class. Antipsychotics are not approved for the treatment of dementia-related psychosis in the elderly.
The warning is explicit and it is unforgiving. Elderly adults with dementia who are given antipsychotics face a significantly increased risk of morbidity and mortality.
Yeah, the source text shows they're primarily dying from cardiovascular issues like heart failure and sudden death, or infections, usually aspiration pneumonia. Plus, there's a marked increase in cerebrovascular events like strokes and TIAs. Why is an elderly brain so much more vulnerable to this?
Well, think back to that messy receptor profile we talked about.
Okay.
The alpha-1 blockade causes orthostatic hypotension, which leads to devastating falls and hip fractures.
Right.
The histamine and anticholinergic-like sedation suppresses their gag reflex and their ability to swallow safely, which leads directly to aspiration pneumonia. Add in the metabolic strain on an aging cardiovascular system, and you literally have a perfect storm.
Wow. So if you are a floor nurse in, say, a long-term care facility, and a provider orders risperidone for an agitated 85-year-old with Alzheimer's, what do you do?
You fall back on the OBRA regulations, that's the Omnibus Budget Reconciliation Act. Federal law states you can only initiate an antipsychotic in these settings if the patient's behavioral or psychological symptoms make them a direct physical danger to themselves or others.
Okay, so not just for being annoying.
Exactly. You cannot use it simply because the patient is confused or wandering or frustrating the staff.
And if they genuinely meet that criteria of being a danger, the text mandates incredibly careful, slow titration. You also have to consider their organ function, right?
Absolutely.
If a patient has renal or hepatic impairment, specifically a creatinine clearance under 30, their body simply cannot clear the drug. You have to start them at just 0.5 milligrams twice a day orally, and you must verify they can tolerate it before you would ever consider giving them a long-acting injection.
Which brings us to step 5 and 9, perhaps the most procedurally complex aspect of risperidone, the pharmacokinetics and administration. Getting this drug into the patient safely is, honestly, an art form.
I have to admit, reading the administration instructions for the injectable versions of this drug, it felt less like standard nursing practice and more like I was reading a manual on advanced chemistry.
It really does.
But let's start simple with the oral medications.
Okay, for the orally disintegrating tablets, or ODTs, the standard rules apply. You must have dry hands, and you peel back the foil backing.
Right, never push it.
Exactly, never push the tablet through the foil, or it will just turn to powder. For the oral liquid, the minimum accurate volume is 0.25 millimol. But there is a massive interaction trap here regarding how you mix that liquid.
Oh, right, I remember this. The liquid is perfectly compatible with water, coffee, orange juice, and low-fat milk. But it is strictly incompatible with cola or tea.
Yes.
And this isn't just about taste. The tannins in tea and the specific acids in cola will actually cause the medication to precipitate.
Yep.
It turns into a solid mass in the cup, rendering it completely useless. Do not mix it with Coke.
Definitely not.
Yeah.
Now let's navigate the complexities of the long-acting depot injections. This is where clinical judgment is just critical. We'll start with the intramuscular, or IM, depots, Risperdal, Consta, and Rakindo.
Okay. The absolute most critical pharmacokinetic rule for the IM injections is that they require oral overlap. But why? Like, if I give a patient a massive IM injection, why do they still need to take pills for weeks?
It comes down to how the drug is manufactured. These IM injections utilize microspheres, so these tiny polymer beads containing the medication. When injected deep into the gluteal muscle, or the deltoid for Consta, those beads act like a slowly melting glacier. Yeah, it takes time for the polymer to break down and release the drug into the bloodstream.
Oh, I see. So if you just give the shot and send them home, they have zero clinical medication in their system for days. They could have a complete psychotic relapse.
Exactly, which is why Consta requires 3 weeks of oral supplementation until the glacier melts enough to provide a steady stream of medication. Rakindo requires 7 days of overlap.
Okay, so that's the IM route. But the subcutaneous or SQ depots, Perseris and Easity, they operate on entirely different physics, right?
Completely different. Unlike the IM depots, these SQ injections form an immediate solid gel matrix just under the skin.
Immediate.
Yes. As soon as that matrix forms, it starts diffusing medication outward, providing clinically relevant blood levels almost instantly. Therefore, absolutely no oral overlap is required. You can give the S2 shot and immediately stop the oral pills.
Wow. But preparing that matrix is practically an athletic event for the nurse. Let's look at Perseris. It comes in a kit with a liquid syringe and a powder syringe. You connect them, and the instructions say you must complete exactly 60 mixing cycles. 5 gentle pushes back and forth to wet the powder, followed by 55 vigorous cycles. Why 55?
Because you are creating a highly precise suspension. If you don't mix it vigorously enough, the polymer won't suspend evenly.
Oh.
This could cause the needle to clog, or worse, it could alter the release rate once inside the patient.
Yeah.
You are literally building a time-release capsule right there in your hands.
And when you inject it into the abdomen or the back of the arm, you are leaving a literal physical lump of medication under the patient's skin.
Yep.
Then there's Uzedy. It comes solid at refrigerated temperatures. You have to let it sit out for at least 30 minutes to warm up. But because the liquid is so incredibly thick and viscous, the text says you must forcefully flick the syringe with a downward whipping motion of your full arm 3 separate times just to move the air bubble to the cap.
The viscosity is no joke. The manufacturer actually suggests standing up while doing this to ensure you generate enough centrifugal force.
That is wild.
And when you actually push the plunger to inject it, you have to push slow and steady, expecting significant physical resistance. If you try to rush it, you could damage the tissue or blow the syringe.
It really highlights how crucial pharmacokinetics are to daily nursing. You aren't just pushing saline into an IV, you are surgically placing a complex, slow-release chemical matrix into human tissue.
Exactly.
And because those depots stay in the body for weeks, or because the oral doses are taken every single day, we have to be intensely vigilant about navigating the fallout, which brings us to step 6 and 7.
Right. The fallout comes in two forms: drug interactions and adverse side effects. Let's tackle metabolism first. Risperidone is primarily processed in the liver by the CYP2D6 enzyme. It converts the parent drug into a metabolite called 9-hydroxyrisperidone.
Now, connecting back to our pharmacokinetic rules, both the original drug and that new metabolite are equally active in the brain. They both do the same job. So if a patient takes another medication that is a CYP2D6 inhibitor, meaning it blocks that liver enzyme, what happens to the traffic?
Well, the liver pathway gets congested. The parent drug can't get broken down, so it just builds up in the bloodstream, leading to toxic levels and amplified side effects. You'd likely need to lower the dose.
Makes sense.
Conversely, if the patient takes a potent CYP3A4 inducer, it revs up a secondary liver pathway, clearing the drug out of the system far too quickly. The patient's blood levels drop, their symptoms return, and you'd have to increase the dose.
This directly ties into the side effect profile, which is honestly staggering in its numbers. We touched on this with our soundboard analogy, but let's review the clinical realities. Mild to moderate side effects include massive metabolic disruption, with significant weight gain reported in up to 32% of patients.
Yeah, it acts as a powerful appetite stimulator while simultaneously altering how the body processes glucose and lipids. And then there's the prolactin issue.
Right.
Because of that strong D2 blockade in the tuberofundibular tract we discussed, risperidone raises prolactin levels significantly more than almost any other atypical antipsychotic.
This is a huge quality of life issue for patients. Elevated prolactin leads to galactorrhea, which is inappropriate milk production, gynecomastia, or the development of breast tissue in men, and amenorrhea, the total loss of menstrual periods in women.
And those are just the expected moderate effects. We have to be hypervigilant for the severe, life-threatening adverse reactions. We talked about the stroke risk in the elderly. But there's also tardive dyskinesia, involuntary repetitive body movements, usually of the face and tongue, caused by long-term dopamine blockade, making the receptors supersensitive.
And the absolute most critical clinical red flag, neuroleptic malignant syndrome, or NMS. What is happening in the body during NMS?
Think of NMS as a sudden, catastrophic crash of dopamine in the hypothalamus. The hypothalamus is your body's thermostat. When it loses dopamine, the thermostat breaks.
Oh, wow.
Yeah. The patient develops a sudden, dangerously high fever, severe muscle rigidity, often described as lead pipe rigidity, and an altered mental status. Their autonomic nervous system just goes into chaos.
If you see that combination of a high fever and stiff muscles in a patient on risperidone, you don't wait. You stop the medication immediately, notify the provider, and initiate emergency cooling and hydration protocols. It is a true medical emergency.
Which perfectly circles back to step 10, how we communicate all of this danger to the person actually taking the drug. Patient education is our frontline defense. So how would you counsel a patient who just received one of those highly viscous subcutaneous injections like Perseris?
Well, you have to be totally transparent about the physical reality. You tell them they're going to feel a small, hard lump under the skin on their stomach or their arm, and it will be there for several weeks. It will slowly dissolve, but they must never rub or massage the injection site.
Which is vital, because if they rub it, they could physically break down that polymer matrix, causing the drug to release into the bloodstream much faster than intended, potentially leading to an overdose.
You also advise them to avoid tight waistbands or belts resting over that area to prevent friction. And tying it all the way back to our receptor map, because we know the drug blocks alpha-1 receptors and stops blood vessels from constricting, you must teach them to change positions very slowly.
Yes, orthostatic hypotension.
Right. If they stand up quickly from bed, their blood pressure will drop and they will pass out.
It is all interconnected. The initial chemical blueprint dictates the side effects, which dictates our nursing interventions, which dictates what we teach the patient.
All right, we have covered an incredible amount of ground. Let's synthesize everything into our final step 12, the nursing school priority summary. We are going to rapid fire the most vital takeaways for you.
I will start with the must-know priority. You must know the black box warning. You avoid risperidone in elderly patients with dementia-related psychosis due to the stark increased risk of falls, stroke, aspiration pneumonia, and cardiovascular death.
The nice-to-know detail. Risperidone raises prolactin levels far more than most atypical antipsychotics because of its highly specific potent D2 receptor binding profile in the brain.
Your test trap for exams. For the oral liquid, it is compatible with coffee and juice, but never mix it with cola or tea, as it will precipitate. And for the injectables, remember that IM depots act like melting glaciers and require oral overlap, while XU depots form instant matrices and do not.
The clinical red flag. If your patient develops a sudden high fever and severe lead pipe muscle rigidity, you are looking at neuroleptic malignant syndrome. Stop the medication and get emergency help immediately.
And finally, your one-sentence memory hook to tie it all together. Risperidone balances dopamine and serotonin to quiet the mind, but watch out for the elderly metabolic weight gain and the complex physics of its depot injections.
That covers the clinical reality of administering the drug. But to close this deep dive, there is one final, incredibly provocative thought buried in the mechanism of action section of this text that we really need to acknowledge.
Yes. There is a brief mention that antipsychotics like risperidone possess neuroplastic properties. This means they are involved in synaptic plasticity, the actual physical remodeling of neural synapses and neurogenesis, the creation of entirely new neurons over an extended period.
Which completely upends how you view a daily medication. It forces us to step back and ask, when we give a patient these medications for years on end, are we merely chemically suppressing their symptoms in the moment, or is this drug fundamentally rebuilding the physical architecture of their brain?
It's a profound shift in perspective, isn't it? If the brain is physically remodeling itself in response to this chemical matrix, it perfectly explains why the full therapeutic effects can take weeks to appear. But it also raises massive unresolved questions about the permanence of long-term use.
Are we just temporarily turning down the volume on the soundboard, or are we permanently rewiring the entire studio? That is something for you to mull over on your next shift. Thanks for joining us on this deep dive.